Okay. So we had an excellent introduction. I just want to review that alcohol and drug use is a serious global health and medical problem, and it affects every demographic group. There's no group that can say it will never happen in my group. So according to the UN, they stated in 1998 that drugs affect all sectors of society in all countries. And I hope everyone saw the movie last night, Unspoken, or have seen it on YouTube, because I think this really speaks to the magnitude of the problem. One of the issues is that drug overdose deaths in the United States, I don't know about other countries, but in the United States, it has climbed dramatically since the year 2000. In Wayne County, this past year, we saw a 61.5% increase in overdose deaths. Before that, it was inching up, but it was pretty stable. In Wayne County, which is where Detroit is, we typically have a high overdose death rate, but last year it jumped. And most of the jump was attributed to fentanyl, which is an opioid. And if you look at the people that were affected, the people who died, we had 10 people where the family identified them as Arabs, Arab Americans. The previous year, there was only one. So one person could say, well, did the population increase by tenfold? And the answer, unless you're a politician, is no, it did not. So either it's moving in and affecting the second and third generations that are now vulnerable, or is it that the families are more likely to talk about it? So just keep those things in mind. In the past 10 years, we've seen changes in the legal status of marijuana in the US and other countries. We have it legal in some states. We have medical marijuana in other states. We have cities that have decriminalized it. Hopefully you saw the headlines about Canada, where they are moving to legalize it. We've also seen the emergence of what we call novel psychoactive substances. You might know them as K2, spice. It's a synthetic cannabinoids. There's also synthetic cathinones. That would be like fake cod. And that a lot of times it goes by the term bath salts. But the biggest one is opioids. That's the reemergence of heroin and the continuing increase in the supply of opioid medications. And it's not just in the US, but it's everywhere. Now in the US, we have taken specific policies to address this. We've expanded medication-assisted treatment. We have updated, and in some states they mandate the prescription drug monitoring program. We just introduced one in Michigan. I don't believe it's mandated to use. There was some discussion about whether it would be mandated. So what it does is that the prescriber can see if that patient is already getting opioids or benzodiazepines from other prescribers. There are guidelines for prescribing, especially with chronic pain. But there's also reformulation of medications to lower the abuse potential. Oxycontin is the typical example. And expansion of harm reduction strategies. We've also scheduled, for example, tramadol, to accurately reflect its abuse potential. And we upscheduled hydrocodone, recognizing it has a much higher abuse potential than previously acknowledged. The FDA requires risk evaluation mitigation strategies, and we've renewed the focus on educating future and current healthcare providers. I'm on a task force at Wayne State that looks at that. And in addition to educating the providers, we need to educate patients and their families about what drugs are and what drugs can do. They cannot address all pain. So you cannot assume that you can get stronger and stronger medication, and all your pain will disappear. Well, as I said, this was an article that appeared in the Journal of Muslim Mental Health, but in 2009, there was a special issue where I was the guest editor. It included clinical reports and community reports. One of our reports was on male and female hospitalized substance abuse patients in Egypt. One was on pathways to outpatient treatment among first-generation Arab Americans. There was a case report on cultural-specific treatment, but we also had reports from the community. One was on negative coping and self-reported alcohol and drug use among manual workers, men in Egypt. And then there was a very interesting article about the provision of personal advice given through the internet about alcohol by Islamic scholars. But to go back to what I'm talking about now is that we wanted to get a handle on the extent of the problem among Muslim communities. As an epidemiologist, I prefer very well done surveys, which would be representative of the population. Very few of those have been done. They've been done in Lebanon and Albania. In Lebanon, they did not ask the religious affiliation. In Albania, they found no difference in religious affiliation by drinking, but they did by the extent of the religious observance. WHO publishes every year a global picture, and they found very low alcohol consumption in Muslim-majority countries, but it's possibly increasing in a few countries, such as Turkey. The major problem, of course, is the high opioid problem in countries on the heroin distribution route. And this is a better picture of it. Afghanistan is the major producer of heroin in the world. To get it out of Afghanistan, where already you have about 8% of the population that's addicted to it, it has to go to other countries. Some of it goes through Pakistan, others go through Iran. So these are major problems when in the environment you have so many drugs. In the United States, with support from ISPU, we did a study looking at alcohol use among Muslim college students. Most of the college students were first-generation immigrants. The risk factors were the degree of acculturation and a lower religiosity. To go along with what you were saying, protective factors are important. This was the parental disapproval of alcohol use, also living in a community with more Muslims around them, where they would be observed the type of behavior that they're practicing. But similar to the general population, having fewer people in their social network who drink was protective against drinking. We've also done qualitative studies, and this is a lot to do with the problem of getting valid responses to surveys. If people know that you're asking their religious affiliation, are they going to mark down, yes, I drink, yes, I do drugs? So what we did is we did qualitative studies asking about other people they knew. And then they told lots and lots of stories. And some of them were so detailed, you know they're talking about themselves. They were very concerned about bringing shame to their family. So what they did is they would hide the behavior from the family and from the community. And that's what we found among young Arab Americans. And this has also been repeated among young Muslim men in Israel and in Canada among Somali Canadians. But that brings us to the issue of getting people into treatment. So I ran across this on a New Zealand website. They were very happy that they were the highest per capita substance abuse treatment population in the world. And that was mostly for marijuana. But I was surprised because I hadn't realized the magnitude of the problem, is that Iran is the second highest in the world. And the drug that most people are being treated for are opioids. And that's directly related to the flood of opioids from Afghanistan. These people are they originally tried to arrest and supply problem, but then they went to the demand reduction perspective, and they expanded medication-assisted treatment, methadone, even beyond specialized center to family medicine. So it's much more open. You're going there anyway for other health concerns. You're also being treated for opioid use disorder. So that's what I said. But they've also have women-specific centers set up. Malaysia is another place that has expanded medication-assisted treatment, and they've even had publications that explain in detail how they arrived at that step, because they argued that it was based upon the principles of preservation and protection of dignity and steering away from harm and destruction. So part of the reason for this article and for this talk is what are the recommendations from here, from a research perspective. Ideally, we could determine the prevalence of the use of a substance, the beginning of problematic use, and the development of substance use disorder without exposing the individual to shame. I was at a training in Dearborn, Michigan, where the monitor contradicted everyone on the panel, where we all said the family plays a very important role and needs to support this person. And she said, women will never do that because they'll be afraid that they would be divorced. So they will hide what their children are doing to avoid being divorced. It's going to be very hard to get that child the support that they need and into treatment that they need if there's that attitude. We need more research on tailored treatment programs, so I'm sad that I'm missing the other presentation. But I think what we really need is online outreach and therapies until people are willing to appear in person. Clinicians need to be trained to screen effectively for substance use and abuse among Muslims, not to assume, oh, they're Muslim, therefore they will not use drugs or drink, and that we need to train other respected and prominent adults in the community, especially about what are the resources in the community. But we have to be careful because this training could actually increase stigma and increase the barriers to treatment. So we need to carefully evaluate this. We need a lot more research on prevention programs. In Dearborn, we're doing one that's internationally recognized. It increases coping skills and social skills, but we don't know how it's being tailored and how it's being accepted by the families. We know that it's being effective with the child, but I need more information and we need to share it with other people. And lastly, I've been talking about heroin and somewhat about alcohol. There's a whole nother drug that's very little information is available on, and that's pot. So thank you.